section head for Headquarter Marine Corps Substitute Programs.
And that's it for Walter Reed.
Great. And this is David Gastfriend. I am an addiction psychiatrist from ASAM, actually representing ASAM, and I conducted the research validating the ASAM criteria and developed the computerized algorithm, the decision tree.
Hi, this is Rob Pickle. I'm the Director of Policy Development for the Office of the Medical Director at New York State Office of Alcoholism and Substance Abuse Services.
Excellent.
Hi,
Right.
I don't know if you guys can hear me. My name is Jonathan Lee. I'm the Associate Medical Director of the Farley Center.
Okay, Farley Center, great.
And then if everyone's okay with this, just to help me with recording the notes, I'd like to record this meeting, and the web page that everyone has a link to will have an encore presentation of this training as well. It helps me sometimes when I'm shorthanded on the notes. So it sounds like we have a pretty good list. So we have, and I'm sorry, so folks, we've spoken with Walter Reed before, but I believe this is our first time speaking with you, Rob, and you, and Jonathan.
Yes.
And what organizations are you with again?
I'm with New York State Oasis.
Okay. And
I'm Jonathan. So I'm with Farley Treatment, the Farley Center at Williamsburg, Virginia.
okay, excellent. Well, the purpose of today's call, and we may have a couple other pilots joining as well. For those of you, I'm assuming everyone on this call has been on the email blast and has heard that we are we are pursuing beta testing of our ASAM criteria software. We have some pilots that are active, and these calls are available for them to join. And in addition to working with the outreach, I'm also providing the support. So we do online training, and this is kind of a venue where they're able to jump in as well. So hopefully some of them might be able to join to share with us some of their experiences. Otherwise, I've had quite a few discussions I'd look to share with the group. But I wanted to introduce specifically the folks from Oasis and the Farley Center on the pilot. This is our kind of conceptual call. We prefer to have this call first. Because of schedules we've gone on, we've had the technical calls sometimes with some of you first. But this is wanted to conceptually talk a little bit about the ASAM criteria software, introduce you into the pilot, and then talk about some interesting developments in the instrument, both on information we've new information we found on the use of the criteria software from Norway, average duration, as well as some of the other functionality that we're working on and experiencing with current pilots. And then lastly, we specifically are trying to see if we can address any questions or issues with Walter Reed for potentially getting them set up for a pilot as well. So I've got an agenda right there, Dr. Gastfriend. I wanted to see if I could turn it over to you.
Yeah. Thanks.
So if I don't know if you could see the screen or not. Wanted to see if we could just provide at least the folks over Rob from Oasis and Jonathan from the Farley Center just a little conceptual overview of the software and the beta testing.
Yeah. Hi, this is Rob. I want to clarify where Oasis is at this moment in time. We have asked another one of our divisions whether they would be willing to take part in this. I'm hoping that they're going to join on this phone call, but it's something that we are having consideration.
Okay.
Excellent.
Rob, what's the entity that you would assign this to?
Our ATCs.
Okay, those are the rehabs, right? The inpatient?
Yes, inpatient rehabs, yep.
Okay, yeah, that sounds appropriate. Good. And how many of them do you have these days?
13.
Okay. And Jonathan, do you want to describe what Farley Center's interest is and also what kind of facilities you might be considering this for?
Sure. So the Farley Center, we do detox stabilization as well as the rehab for residential style, and anywhere between about a week to a couple months, depending on the patients who come in. So I did talk to our executive director, Don McCourtney, and our medical director, Melissa Warner. So they are interested in understanding what the pilot means and whether or not we could get involved as well.
Okay, great. So, Tony, do you want me to start with the conceptual stuff now?
Yes, if you wouldn't mind. And also on this link, I'm going to be continuing to update this page with resources that we have. So folks who are remote, please continue just to kind of refresh the page, especially pull this up later on so I can provide you those resources too. Specifically for the Farley Center, I'm going to update the page with all of our outreach information regarding the pilot and our goals and objectives.
Great. So all right, let's just quickly review what the ASAM criteria are. This is this thick book, which was 380 pages in the second edition revised version, and became endorsed by a majority of U.S. states for managed care placements in their Medicaid and single state agency funded care, and essentially other insurers within the state ended up being obligated to follow them. The problem with the ASAM criteria is that the rules are so detailed and thoughtful and intricate that nobody can use them. There is no agreement when different raters use them, and I've actually studied this problem. Even when you have a managed care company doing a professional assessment of utilization review, even within the managed care company, the first utilization review person who's calling the treatment program will think that the ASAM criteria says the patient should go to this level of care. Then the program appeals, so a reviewer above that person will review the same exact information, and it's actually written, so we know they're reviewing the same information, and half the time will change the level of care. Then a medical director gets called in and will change the level of care again half the time, and there's literally no consistency in how people are able to use the ASAM software. I mean the ASAM book. So hence the need for ASAM software. And the software was commissioned actually beginning almost 15 years ago, no, 18 years ago, by NIDA in a series of grants to me and my group at Massachusetts General Hospital and Harvard Medical School. And we took the adult admission criteria and computerized them. So we took every single decision rule in the adult admission criteria and broke the rules apart into their decision components, found research quality questions, generally from the literature, and where none could be found, we wrote new ones, but using the principles of good psychometric assessment, and constructed a counselor-guided computerized interview so that the computer provides the counselor with the questions, the counselor asks the patient or makes their own determinations for some of the items and inputs the data, and at the end the computer does a quantitative algorithm and literally calculates the algebra for the entire ASAM level of care. And over many studies over the intervening years and many grants, $7-8 million worth of research grant, we have good data that when two different counselors use the software, 77% of the time they come up with the same answer for level of care, which is a very good inter-rater reliability, and in fact is better than a lot of DSM-4 diagnostic agreement. And when you use the software and place the patient in the appropriate matched level of care, you get a variety of better outcomes. So you have studies showing that you have better engagement into the next level of care, better 1-month outcomes, better 3-month outcomes, and better hospital utilization over the coming year. So a lot of different studies and findings. The most recent study has been of this particular algorithm, this version, in a version translated into the Norwegian language and used throughout Norway in a multi-site study with 400 administrations, and patients had better outcomes in several different ways that it was looked at if they were matched compared to if they were mismatched. ASAM wanted to make this available throughout the field, and because it was a research version developed by a research institution, nobody could really manage the technical support of such a thing in the commercial distribution. So after a lot of effort and a one-year-long study by Harvard Business School with all kinds of recommendations about how to do this, SAMHSA picked up the ball and commissioned the company that is coordinating this call today, FEI Systems, to rewrite the software for a web-based application so that any counselor in a treatment program could access the software as long as they had a browser and a computer. You don't actually download software. You simply access the server, and it operates essentially in the cloud. The beauty of that is when we revise the software, as we will do in October for DSM-5, and for the new ASAM criteria version that's coming out, the next day when that's done, if the counselor is using the software, they open up the software in the cloud, and it will be the new software. They won't have to remember to upgrade it. They won't have to, download software. It'll happen automatically, and everybody in the country who's using it will have the new version on the same day. So, we owe some thanks to SAMHSA because they really had vision. And they wanted to do this to prepare for the era of health IT. They commissioned the software to be set up so that it could interface with electronic health record systems, and it will be made available to vendors. So systems that already have a vendor and an EHR, and they want their vendor to be able to connect the ASAM software into their electronic health record. The vendors will be able to do that. They won't need permission. They won't need to start from scratch and build it within their system. So it's a very modern, rational way to do decision support software. So that's the basic background. And the instrument itself is, as I said, a computer-guided structured interview, heavily branched. There are, I think, literally 6,000 branching points possible in the software. There are perhaps 1,000 different question items. No patient would ever get asked 1,000 items because the reason there are that many items is so that all different kinds of patients can be appropriately explored. The Norwegians, who've done 400 plus of these assessments, have averaged 110 minutes per assessment. So less than 2 hours, more than an hour and a half on average. And the software is made so that you can stop in the middle and have the patient go to the bathroom or go get lunch or come back the next day. You could stop several times if you need to. It doesn't hurt it in any way. The patients and the counselors who've used the software have been asked what they think of it. They both think it takes a long time. But the patients say that they like it. Actually, they like it a lot because they feel it got more information and it asked them more important questions than they have been asked in the past. The counselors say that despite the fact that it takes a long time, that they like it, and they say it's because they find it makes them better counselors. And maybe we'll have a chance to show you in a little tour of the software what they get from that, why they think that. We also gave a tour of the software at ASAM's annual meeting this past April in Chicago to 140 ASAM physicians. And they actually used the software to input data from a mock interview. And we did a satisfaction rating with them. And about 3/4 of them said they were moderately to extremely interested in implementing the software for themselves. So we have gotten input from a lot of different places that the software is filling a need. Now, there are a number of things that will be done with the software after the initial launch. The full launch will be at the end of October at ASAM's State of the Art Conference. SAMHSA and ASAM will jointly launch it. And it will be DSM-5 ready, and it will be ready for the ASAM, the new edition of the book. But you can start using it today because we are beta testing it, and it is already being used in a number of places. And there are, I don't know, 15, 20 places that, or systems rather, I shouldn't say places because each system can have multiple places. So there are 15 to 20 systems that have said that they want to start a pilot with it. And that is fine. We're looking to have it used to find what are the reactions, what are the critiques, and also ways to improve it. One of the reasons SAMHSA wanted this done in the cloud is so that it could be easily improved. You know, at pretty much every week there could be an improvement done, and it could be added to the software, and that would be transparent to the end user. They wouldn't have to worry about having that implemented. So let's talk about what it takes to do a pilot with the software. Ideally, the first place to try it is in a residential rehab level 3 type program, because you have the patient sitting around for a number of days, and you have staff, and generally you're doing an intake every day or maybe a couple intakes a day, but you have the time to get used to it. And there's a pilot educational program. It's not really a full training. There's no certification at this point, but there is this mock interview that's up on the web, and we can give you the links to it. And you can watch me interview. Oh, let's do it. Go ahead, play a little bit of it.
I'm not
interviewing a mock patient.
I'm not sure if the audio will come out.
Oh, okay. Well, anyway, you'll see the interview of a mock patient to whom I am related by marriage, and hope to stay that way for many years. And then there is a, you can see how it's being input, because at different times the screen pops up an image of the software, which looks like this. And you can see what the different types of input items are, scroll downs, the click boxes, the radio buttons, and so forth, and how to scroll, and then eventually how to save, and then how to print out a report. So once you've gone through that, you're pretty much ready to start using it. It's surprisingly simple. And since we're not doing this for research purposes, you don't have to worry, well, what if I don't do the input exactly perfectly? You're not going to blow anything up in the process. And the report is several pages long. It's not a full psychosocial narrative, but it has, actually, if you stop there, I'll point out, on top, there's a listing of what substance abuse diagnoses are met, and how many criteria of each diagnosis are met, and how recently the use of the substance was, if it's alcohol or other opiates. And then below that, there's the CIWA and CINA withdrawal scales are scored in the course of the interview. And it says what the score is and what the range is. And And then it goes into risky issues, dangerousness issues, and ultimately it prints out an ASI composite score in each of the ASI dimensions, both numerically and graphically. I should point out that the full ASI is administered in the course of this interview. The ASI is the heart of the interview and makes up about half of the questions. The reason it's not a full interview is because you don't get enough information from the ASI about motivation, prior treatment experience, psychiatric symptomatology to do a full ASAM level of care determination. And remember, when I say that, what I mean is to do a comprehensive and reliable and valid ASAM level of care determination. There are a number of states that have a one-page ASAM form, and they say, here, you can use this and do the ASAM. The problem is that's not meaningful. There's no way to know if that really does capture what the ASAM criteria say about that patient, because it's all guesswork and approximation. This actually takes into account every piece of information you must know in order to decide every decision rule that would apply to this patient. So you get, we go down to the end, you get a printout of critical items, you get an analysis dimension by dimension, because you have very detailed information by each dimension. And then you see how did the computer resolve the different levels that could be eligible on each of these dimensions into a final recommendation. And so we'll go down to the final level of care recommendation. Oh yeah, you have to consider access to treatment issues, which the ASI doesn't by itself give, and then the final level of care recommendations. And just scroll up one more row. Yeah, good. Leave it there. Okay, so a final thing, just conceptually, to remember is that no computer algorithm should ever take the place of clinician judgment. And even when it comes to the ASAM criteria, the judgment has to be clinically determined, and it may differ from the ASAM software for a variety of reasons. The first being, what if the software is wrong? We have to, as scientists who develop this thing, we have to allow for the possibility that we got it wrong. Every hypothesis is subject to the null hypothesis, meaning that it was not successfully proven. Another thing is that the patient may be recommended for a particular level of care, but the patient may refuse that. Now, there is a question sequence in there that takes that into account. So hopefully it's quantitatively considered. But it means there might be an ideal level of care, but the patient might not be willing to go to it, and then you still need another ASAM-compatible recommendation. The level of care may not be covered by insurance or may not be available in the geographic area that the patient has to be treated in. So there are a variety of reasons. And what happens is after this information is provided to the counselor and they make the placement, they come back to the software and do a completion segment where they indicate if the patient went to the level of care or is going to the level of care that was recommended by the software. And if not, they actually are asked to input an explanation for the discrepancy. And that leaves the final determination in the hands of the counselor, not the computer. And for you large system folks, Walter Reed and Oasis, I predict that you're going to be very interested on some periodic basis, maybe quarterly, maybe annually, to look back and find out why the discrepancies are happening and what proportion are discrepant. Are you getting a lot of discrepant placements because you don't have outpatient intensive care or partial hospital in a variety of locations where it turns out there are pockets of patients who need them? Even at the Farley Center, you may want to look at how often is opioid maintenance treatment being recommended by ASAM but being rejected by your counselors? And does that reflect a need for more training, more education, or work with biases or attitudes? So the final recommendation is not a single recommendation, but it looks something like this. So for Mrs. Jones, at the bottom it says the patient met criteria for placement in level 4, but she indicated that this would be unacceptable to her for treatment. So this requires some other ideas. So now let's go back to item 1. She could be considered for a level 2.5 and 3.1 combination. So a combination of partial hospital but residing in a residential program. Now, some places have that and others don't. Number 2, if she's going to be in that with a level 2.5 for the intensive counseling, she would be best treated in a dual diagnosis enhanced program. Okay, so now that's, again, a more specialized combination of these programs. Number 3 states that she would be best initially treated in level 3.7. So that's medically monitored, intensive inpatient treatment program that's a 24-hour, 365-day available program. And then it goes on into a little bit of explanation. 4 says co-occurring mental disorder. 5 says might need level 4, which is hospital. And 6, if she goes to level 4, she's going to need equal attention to a co-occurring mental disorder and so forth. And 7 says she's actually met some criteria for opioid maintenance therapy, but not the final level criteria. So that would not be an acceptable placement. So one of the things we've learned, not just from prior use of the research versions of the software, but from, for instance, the VA adopted the ASI nationwide, and ultimately what happened is people stopped inputting any data into it. It turned out to be a systemic failure. And one of the reasons for that, we learned, was that the counselors felt that they were no longer serving as counselors, but they were being utilized as research technicians in a way, and they didn't like that. What we wanted to accomplish in this software is to have the counselor's judgment play as much a role as possible, but to structure that judgment, inform it, and constrain the way that judgment is expressed so that a counselor's judgment in Peoria would be the same as in Poughkeepsie. And we also wanted the decision-making to be reliable, predictable, standardizable, so that a patient in either place has the right to get the same quality of decision-making and the same application of science. It shouldn't be, well, in one area it's a counselor's charisma that makes the difference of what they get. And in another area, it's, they don't believe in certain treatments, they don't use them, so they don't even discuss them with patients. That's not modern science. It's not what NIDA's research and NIAAA's research has taught us. So that's the reason for the software. And one last conceptual point is we found that counselors don't like using quantitative rating scales. Just rating a 1 through 10 of a patient's craving or motivation. It doesn't feel clinical to them, and when they're told by a lot of these research instruments, ask the patient to rate their level of craving on a 1 to 7 scale, where 7 is the worst ever and 1 is no craving. The counselors don't like being asked to do that. So when we structured the interview, we left out numbers as much as possible. And for each number, instead, we put in words, phrases, statements, so that the counselor could understand why is the first item on a list less severe than the second item, and why is the thing at the top of the sequence the most severe? What does it really mean about a patient? So that they could understand how to differentiate in their own minds a patient with more or less severity. Now, does every counselor need it done that way? No. The more experienced a counselor is, the more they do assessment like this software. So the expert clinicians aren't going to be changed much by this. They'll just standardize their work much more. But the novice counselor is remarkably successful if they use this software in achieving an understanding of the patient and a recommendation for level of care compared to an expert clinician. There is a difference. The experts still do better, and the outcomes of their placement still do better, but not a lot better than novice counselors. And that was a critical goal of the software, so that a state system or a VA or a DoD system could have turnover, could have counselors leaving and being replaced, and still expect a minimum strong level of competency in the intake process. So let me stop there and just see what kind of questions you have about the conceptual level, and then if we have time, we'll go through some of the question sequences, and I'll illustrate this in more detail. So anybody, feel free to ask questions or comment.
Dr. Gastfriend, I have a question. I'm going to try to ask it on behalf of Milwaukee. They apparently have not joined the call, but they had a specific question on the report as it relates to the software. So I was going to show. So one of our pilots, they're currently using the system and have a report, and they wanted to know what the correlation was between this question. We can dive into the software a little bit, but they wanted to know what the correlation was, what the intention was between this question. What are acceptable levels of care for which the patient's mental status is sufficiently stable and adequate to participate in the therapeutic interventions and to benefit from treatment? The correlation between that and the report. I didn't know how to answer that. I encouraged them to join the call, but I'm asking it as best I can. So the question was, given that, what is the relationship between that question and she was looking at this dimension analysis? Is that something, did I ask that well enough?
So here's what I think the answer is. We can check to see what the algebra is on that item discretely, because in the documentation, which by the way is available to all of the sites, you can actually see the documentation of all the questions and how they fit in the sequence. But what we do here is at the end of the assessment, you've assessed alertness and concentration and patient's reality testing and judgment. And even a novice counselor has done a reasonable job of that because they've been structured to do it carefully, step by step, even if they wouldn't know how to do it, out of their own training yet. The algorithm takes into account a lot of those discrete answers and figures out if there are levels of care that wouldn't work because the patient has frank psychosis or is acutely suicidal or has trouble with concentration or memory. But just in case we don't have enough questions or the questions don't cover all the different aspects of cognitive function, we ask the counselor, after they have been prompted to think about all these different symptom and function characteristics, to make their own judgment. And you'll have to check me on the algebra, but I believe this answer, you might think it's subjective, but it's not, because there's been so much detailed information provided already at the point that this decision is made. So the counselor gets to use their judgment in addition to sort of the mathematical calculations that have preceded this question. So it's sort of a clinical check on the math at this point. Does that make sense, Tony?
That does, and I will relay that back to Patricia over at Milwaukee. So hopefully that answers it. I can also direct her to the snippet of this. So that answers it to me, but hopefully I'll get confirmation with Patricia. So thank you. We have a couple other questions too. If we do a tour of the software, that obviously we'll have the questions of folks on the call first, but then we have about 24 other kind of different questions and discussion topics that have been raised by individuals. But obviously, want to make sure we take care of who's ever on the call first. But
I'd like to ask one question, Dr. Landy from Walter Reed. I was just curious in listening to your presentation if the software or the algorithm takes into account a test taker's bias towards non-disclosure.
Yeah. So are you saying patient non-disclosure?
Correct.
That's a bias? Yeah. So the interview, another reason it follows the ASI is because it was learned in years of using the ASI that you don't want to start the interview by saying to the patient, so you drink a lot, right? How much do you drink? Because obviously that's going to inhibit an unbiased response. If you start out by asking about medical needs, it feels less stigmatized, and the patient tends to be willing to talk about those things. And then if you progress and hold off the drug and alcohol questions till later, hold off the legal questions until after those, hold off the psych stuff until the end, because it turns out a lot of substance patients think psych stuff is even more stigmatized than their substance use. So that sequence has worked remarkably well, and it turns out when computers are involved, it's been learned over decades, starting with VA research in the early 1980s, that patients are not put off by computerized interviewing or computer-assisted interviewing. In fact, once they get the hang of it and they see how it's going, they actually find some comfort in it. So
Been our experience here too. So what you say makes clinical sense. I'm curious if you've tested that. Clinical observation that the structure of the interview that you put into the algorithm actually facilitates disclosure. Has that been research tested, or is that just?
It has not been tested with this structured interview. We've just reviewed extensively the literature on this topic and concluded that this is the way to go.
Fair enough. Thanks.
This is Barbara Marin from Walter Reed, and you might be getting to this later, David, but I was wondering what training is needed. I know you've spoken in our past conversations about a learning curve, but what about the preliminary training before one can begin using this?
So, Tony, we have some sites using it now that have basically just done this. They've had the conceptual presentation, and then they've done the tour, and then they've basically just gone in, done the, they've reviewed the mock interview, which is an hour and a half long or an hour long, and then they've just gotten to work using the software. Isn't that right, Tony?
yes, that's correct. In fact, what I'd like to show on the page, each one of the training sites, I do a go-to-meeting with them, and I've recorded our sessions. Milwaukee's an excellent example of that. Each one of them has a page, so when they have the training, they're able to if they want to try it on a test patient, they can watch the interview and go along and follow, their assessment at home or wherever their work environment is and perform the assessment. And then we provide the, helpful articles as well as the video training, so they can go, for folks that, perhaps are joining later, they can go ahead and watch the training. I've got links to it in this kind of an encore presentation of all the training. So typically we will have one technical training to walk you through, and in that training we put the tool directly in the user's hands. We ensure that they can access the site using preferred browsers, and it looks well. And then on the second call, it's really just it's a launch. We expect the users to be able to access the software during that time and let us know if they have any issues while they're running through the mock patient. So so far it's worked really well. It's Milwaukee's probably been our best success story, as we were able to roll out the training to I believe it's 9 individuals, and it was basically 2 training calls, and they've been running through it, and they've provided some really neat feedback so far. And obviously, we've been able to make some improvements to the software just with their use. They're really using it very well.
Thanks.
So in terms of for Walter Reed, was just curious. One, our impediment so far has just really been the ability of the equipment where you would be, administering the interview, having the authorization to access the software on the cloud, which is, it's private and it's located outside. It's not hosted in the Walter Reed environment. So from a technical perspective, we are ready to credential users and have it hosted in a secure, compliant environment. And it's really on our part. I was just curious, since we're talking, if there's been any updates in terms of receiving the authorization to kind of engage with using the software hosted where in its current environment. Is there any update on that part?
I'm afraid there isn't. We've had a lot of really serious system-wide technical problems this week in our Outlook, so serious communication piece. But I have inquired on several levels to the relevant players, and I'm hoping next week I will be able to track them down in person, if not by email. We are very interested in it, and I have a guarded measure of confidence that it will work out. Dr. Landy has a comment.
So it might help, Dr. Marin, if you could perhaps send her some technical details, like the degree of encryption that you're using on the server. Okay. Anything else that go towards HIPAA compliance issues?
Absolutely. We have I'll provide that. We have, I'll put together a page just for all the specific items you're requesting. We are your business associate. We have an agreement put together, but we're bound by it even if we didn't show it to you. If we are hosting your environment, and this is a facility that's currently hosting, not only HIPAA compliant, but 42 CFR Part 2 compliant, which is perhaps even more stringent for 28 states across the country. So we absolutely have some technical information we could provide as well. My understanding is that what the real impediment was, and I absolutely can provide that, but there's a DIACAP process that if that were required, that would effectively push the pilot date back in an optimistic scenario 6 months. And
so well, it seems like we're hoping we'll be able to bypass that DIACAP because there's no software that's going to come down to our computers. As of our last conversation, we were talking about having standalone computers or laptops that would directly access the intranet through our Wi-Fi system and would not compromise our network equipment. So as I understand it, Tony, correct me if I'm not stating it right, but I think that's what our goal is, to get approval for government-furnished equipment that would stand alone, directly accessing an internet.
So if this is done over, I mean, really, here, I hate to be too critical, but our email's been down for a week here.
Yes, I'm familiar with several drawbacks of email. You'll see I try to use the web page as a more consistent way for getting information out. I've been burned on a couple calls.
Is that the Syrians or the Chinese now?
It's going to be a bandwidth issue too, perhaps.
Yeah.
So it's going to be bandwidth and encryption, and that's the kind of stuff I'm sure IT is going to key on, and HIPAA compliance.
Okay. The other thing, too, that we have available, we have a method of putting in de-identified patient information, which is, for example, Milwaukee has chosen to use that. Even though it's securely hosted, their patients feel more comfortable that they don't have anything identifiable in an outside system, and that patients exist only as numeric entries, with their de-identified number that they have private to their organization. So in addition to their being hosted in a HIPAA compliant way, it's belt and suspenders approach, where not only is it HIPAA compliant, but there's also no patient identified information in there. So an abundance of caution.
I'll make every effort to get back with you next week one way or another. And,
Okay.
maybe we can set up a phone call with the relevant players in the command structure for IT so we can just iron this out as quickly as possible.
That would be excellent, and we have so we can follow up on offline on that, and yeah, so we are looking forward to it. And then, like I said, we would distribute. I'll put together a page just for you guys. So if there's anything specific you need to have, you can access it very readily, and that's how we actually work with all the other pilots too. It's a convenient way for me to communicate to them any training materials that they need or feedback. So.
Well, for starters, we'll stick with Dr. Landy's items. I know you sent us something previously, so if you consolidate both of those lists, then we'll put that out and see what else is needed.
Okay, absolutely.
Thank
That
you.
was in an email that you sent earlier this week, I believe Wednesday the 28th.
The dates are
Okay.
very confusing because
Oh, yes. Okay, I won't reference it by date. So, okay.
This is Rob. I just want to clarify that I understand this correctly. So the patient responses are in fact uploaded, whether they're de-identified or not, and that the process, the evaluation process, I'm assuming takes place basically in the cloud as opposed to on whatever what do you call it, computer is they're using to administer it.
Exactly.
Okay.
Dr. Gasser and I have it available. Either way, we could show the software as is, as it's currently being viewed by the pilots that we provide the training on, or we could use the demo site, which has a slightly enhanced UI, but it's not what the pilots currently have. If you like, we could.
That's okay. I have it up on my screen, so do you want to just transfer the
Yes.
screen ownership to me, and I'll take over?
Absolutely. Let me move it over to you.
Show my screen. Okay, I am the new presenter. Okay, well, this is a sense of power. Oh, wow. Are you seeing?
We are seeing your screen.
Okay, you seeing my cursor move?
Yes.
Yes.
All right, and when I move, you see that different questions are highlighted, and it looks like blue to me.
It looks like blue over here as well.
Okay, good. So on the left-hand side is the outline of the interview and also the way we indicate to the counselor where they're at with the patient in the course of the interview. You're allowed to jump around. So if you have a counselor who really can't stand being structured and wants to, give the patient a lot of room to jump around and feels that that's maybe for a particular patient going to comfort them and help them best open up, this is set up to allow that. So the sequence is general information, medical history, employment, and so you've done already, a quarter of the assessment before you get into stuff that is really judgment-laden, at least in the patient's perspective, to allow time for, the collaboration to establish itself. And then it goes through legal, family, social, and psychological is near the end, just as it is in the ASI. And then I mentioned there's some interview completion questions, and after the final level of care is decided upon and the patient has decided to accept it, then you have to go back and review. So there are different questions, and at each point it tells you how far along you are, if you're 20% completed, 50% or whatever. The question sequence appears to the right and is a scrollable sequence, but you don't have to use the mouse to scroll. You can actually stay on the keyboard if you want and use the return key or the enter key. So the interface is as comfortable as possible. Now, in medical history, we need to do a review of systems, and that's what we call it in medicine. But counselors generally don't even know where to begin with these things, nor should they. It's not something that they are necessarily trained in. So they're going to ask, instead of filling it out like a physician or a nurse would, they are going to probably enter into it through structured questions. So the first structured question, and questions have an icon associated with them. Instead of here where you see only a single person icon, here you see a double person icon, and that means it's a dialogue question. You also can tell it's a dialogue question because it's in quotes and italics. So very quickly the counselor figures out, oh yeah, those are the questions I've got to ask the patient. So the counselor literally says, oh, how many times in your life have you been hospitalized for medical problems? And the patient might say, yeah, I don't think I've been hospitalized for medical problems. And then the counselor is prompted to go a little further and say, well, what about for like overdoses or DTs, delirium tremens? And the patient might say, oh yeah, I had to go in the hospital I did have the DTs, and I was throwing up and going crazy, and they hospitalized me. And then there was the time, since you asked, I went in for detox. And so it explains, don't put it down for detox, so that would be a 1 here. And then next dialogue question, how long ago was your last hospitalization for a physical problem? And it's pretty clear you've got to put in a number of years and a number of months. And do you have any chronic medical problems which continue to interfere with your life? And the answer is either yes or no on that. And what are the chronic medical problems that continue to interfere with your life? So anyway, it goes through a whole bunch of questions. And it asks sexually transmitted diseases, and after the patient gives an answer, there's more detail to be probed. So just like an expert clinician would do, ask a general question and then go to the more specifics as the patient answers, this follows that same style of interviewing. So that's some of the aspects of the medical history. Now but it asks about things that a counselor might forget to ask about, like TB. And there are a number of things in a substance abuse interview where you really do need to be sure you asked. So it's set up to make sure that every single patient is routinely asked these things. In fact, the reason this is in a darker background color, it looks kind of greenish on my screen, it might look yellowish on other screens, is because if you don't answer this question, the algorithm will not score. So there are a lot of questions that don't have to be forced that way, but there's many that do. Now let's look at how drug and alcohol questions proceed so you get a sense of the thoroughness of this. The first thing is that each of the categories of illicit or reinforcing substances has to be asked, because a patient might think they use something, it's not even a drug, I don't have to tell them about it, but it might be their sleeping pills, and that might be actually the most important item. So the counselor has got to answer this whole sequence of questions. And as they go through the sequence, they're going to cover recency and frequency and route of administration. When was your last use of alcohol? How many days did you use it? For how long in your life have you been using it? Alcohol is an oral drug, so PO, but cocaine obviously can be used several different ways, opioids several different ways. Have you used it to the point of intoxication? And then again, the recency and the frequency. And it develops all of the information needed to answer the DSM question, the criteria. So the tolerance, the withdrawal, use in hazardous situations, all of these items are structured in a logical sequence. And then it will go into the withdrawal scales. So this is a patient who had some opioid use. So you'll see there's a whole sequence of questions about withdrawal. And the format of these answers can be different. So here, the CINA withdrawal scale for opioids has a question about nausea and vomiting. And it's a 0 to 9 scale. So the counselor might not really be familiar with that. We don't expect counselors to be research assistants who would necessarily know that. So we provide English language wherever appropriate. So 0 is no nausea. 1 is mild nausea but no vomiting. 2 gets you into dry heaves and no vomiting. And there's a range of possibilities there. 5 gets you into dry heaves, which are frequent, and vomiting. So you can sort of figure out as a counselor how to score this patient. You might not be exact as a research assistant might be, but you're going to be definitely within the right ballpark, just because of the way the English language terms describe the cases. Now, another thing about this interface is that green represents a healthy or less severe response, and red is a dangerous or most severe response, just like a traffic light. And that's a color convention that pretty much everybody understands. So it's just a nice aspect of the user interface. Now, another thing is that physical exam things are taught to medical residents and addiction physicians and detox nurses learn these things, but the counselor generally doesn't. So how do you help a counselor to do an assessment of something physical like tremor? So it says arms extended, okay. Mr. Patient, would you mind putting your arms straight out in front of you? Okay, and fingers spread. Could you spread your fingers out? And then it's an observation. So it doesn't say 0 here, but to the computer, it's read as a 0. And to the counselor, it's no tremor. Or no, not visible, but can be felt fingertip to fingertip. Oh, okay, so I'm going to put my fingertips against the patient's fingertips and feel, wow, there's a weird thing going on. These patients' fingers are trembling, but I wouldn't see it just holding their hands out, but I can feel that they are trembling. Or moderate tremor, even with the patient's arm extended without touching the fingertips, you can see it. Or severe, even with arms not extended and relaxed at their sides, the patient's arms are trembling. So here we have a 0, 1, 2, 3 rating, each of these in English, very clear what they mean, very clear that the 1 is quite different from the 2, and the 2 is quite different from the 3. So once your counselor has done a few of these and figured out what everything means and that there are these distinctions, they can start putting in answers that are very reliable, and they like it because they're realizing, oh, now I can actually tell a patient who's trembling when they just stand there versus the ones who, it's only when they reach out to shake your hand and they touch your hand you can feel they're trembling. And so they like that because they're learning constantly and getting better by doing these interviews. All right, we'll just do a couple more. I'd like you to see how we rate attitude and motivation, because that's kind of complex to structure. And so when we get into, we've asked recency, frequency, in some cases quantity, although that's generally not the key to diagnosis. And we've done the DSM criteria. Now we're going to ask about relapse, risk, craving, and things like that. So imagine yourself in the environment in which you previously used, and in this case we might say alcohol for this patient. If you were living in this environment today, what is the likelihood that you would use? And the patient might say, oh, I'd be using it every day. Well, okay, that's extremely. How about rate how strong your urges are for a drug or for alcohol when something in the environment reminds you of it? And the patient might say, well, I know when I drive by a liquor store, I find myself thinking about it for the next half hour, and generally when I get home, I'm thinking, I need a beer. Okay, we'll rate how strong is your desire to use any drug right now. So you see what's happening. First, we're asking about likelihood of use, then cue, responsiveness, then desire right now. Now, have your addiction symptoms increased recently? Oh, yeah. And then now the counselor is prompted to ask, how? Well, I've actually been drinking a lot more than I used to, even a month or two ago, before whatever happened. Well, have you had more craving? Oh, yeah. I'm wanting to drink right in the morning when I wake up. How about risk behaviors? Well, yeah, I haven't been showing up to work some mornings because I felt like they'd know I was drinking. They'd smell it on my breath, so I've stayed home. More frequent use, I might not have to ask because the patient just told me that. Increased amount, I might not have to ask because the patient just told me that. So now we have to structure these responses to be very precise. Otherwise, we don't get reliability. So the patient clearly didn't say no. The patient clearly has increased thoughts or craving, at the very least. There's some risk-taking behavior, skipping work, which could end up getting them criticized or even getting a warning. Relapsed, but to less use than using before, or increased use. Well, this patient clearly told us she's drinking more than before. So we know the answer. And this is, as you can see, way better than a 0, 1, 2, 3, 4 response. But the computer reads this as a 4 so that it can quantitatively calculate this rating in the algorithm. So it goes through these very practical functional questions for craving. And now it's going to prompt the counselor to ask about motivation, because in dimension 4, that is a critical consideration. So do you have any concerns about pursuing treatment? And the patient might say, no, I know I have to be here. Well, then the counselor is prompted to ask further. Would anything possibly hold you back? And we go through this one at a time, such as money or insurance. No, my insurance, I have insurance. My job gives me good insurance. How about schedule? Well, what do you mean schedule? Well, like if we put you in day treatment, would that disrupt your schedule? Oh, my schedule would be a problem because I have to work. Okay. How about attending groups? Oh, no, I can't attend groups. I thought you were seeing me individually. Okay. How about having to take medicines? Well, I don't want to take medicines because I don't believe in medicines. Okay. How about drug tests or drinking or drug-using friends? Now, the sequence of concerns is no, there's no concerns, fully participating, or the second one is no concerns but open to participating in any treatments. Then there's passive or hesitations. Then there's specifically resisting single components, and most severe on the motivational agenda is rejecting or obstructing the plan with many contingencies. So even a novice counselor, if they are patient and explore with the patient these specific ideas, is going to get enough information to, maybe they'll be a little confused between whether 4 and 5, or is it 3 and 4, where's the boundary there? But they're not going to confuse these two with these two. So the ability to discriminate between the patient with one severity versus a different severity becomes very good as soon as you start structuring input this way. Let's go to the interview completion, or actually the review section. And you'll see we've placed the patient is going to go to whatever level of care, and that does not agree with what the printout said we should ideally choose. So to justify a disparate levels of care recommendation, did you, Mr. Counselor or Ms. Counselor, differ with the final recommendation of the software due to a dual diagnosis issue? Or was it functionally most salient on dimension 3, 4, 5, or 6? 1 and 2, generally there won't be disagreement. If the patient has to be treated in detox, they're going to get a setting with detox. But what about these other dimensions? So as the counselor has more occurrences of discrepancies, they're going to start thinking about, I don't think this patient would do well in whatever level of care was recommended because of they're craving or because of their past conflicts with family on the environmental dimension or whatever it is. And so we want to actually get that discrete reason for discrepancy, because then we can go through the algorithm in the data that we gather from many, many counselors and see the patterns. And maybe there's something wrong with the software. How do you rate the quality of service you have received? Now this is actually, this will be fixed. This should be asked to the patient. And if a friend in need of similar help, if a friend was in need of similar help, would you recommend our program? Do you agree with the type of treatment you're getting? Do you intend to follow through? If you don't agree with the type of treatment you're referred to, do you think you need less intensive or more intensive treatment? This is a very important issue. When patients disagree, we don't just tell them, I guess you need to go out and do more research, which is what sometimes AA recommends when people aren't ready for AA. We want to find out what the patient thinks, because maybe we can negotiate with them and meet them where they're at, and over time engage them towards the intensity that they need. So there's a whole bunch of satisfaction and functional satisfaction questions. And if the patient isn't going to the level of care that was recommended, there are many reasons that are options. So the patient's choice, unavailability in the region, lack of physical access. Maybe there is a program in the region, but the patient just can't seem to get there. Family or job responsibilities might be an obstacle. Insurance, has insurance, but insurance will not improve the treatment. This is very important. If we see patterns of certain insurers rejecting key levels of care, large systems need to aggregate that data and figure out how they want to address that. Lacking openings or waiting lists too long. If OASIS finds that there are programs, they are paying for slots, they're good quality, but they're just not opening fast enough for patients to get in, and then what do you know? The next thing, they're in emergency rooms. Or the program rejects the patient. Oh, we don't take suicidal patients. Well, wait a minute. We have data showing that these were patients who had suicidal ideation, and I didn't show you this, but the assessment will determine whether they had urges, plans, and capacity to contract for safety. So there are a lot of different reasons the patient may not end up in a placement, which could be quite legitimate. And the counselor gets to figure that out, and the system gets to gather that data and aggregate the patterns. So let me stop there. And the next step would be to literally go online and look at the mock interview and how it's completed and fill it in using the software. And after that, the counselor's ready to try a patient. Questions, observations?
Hi, this is Barbara again. I have a question for Dr. Lanty, who had to leave, but we share his curiosity on the psychological one. I know we don't have time to go into it in depth, but just curious what the questions will produce. Does it go through all the main DSM categories with criteria, or is it, what is it aiming for?
It aims for symptom patterns, but it does not attempt to produce a full diagnostic review. So it'll come up with areas of symptoms. It'll go through all the key areas, thought disorder, behavioral, relationship disorders, depression, anxiety, mania, attentional symptoms. But given how long it takes to do a SCID or a fully structured diagnostic interview, and the fact that counselors really don't have familiarity in that area to the detail, we did not attempt to do that in the ASAM software assessment.
Attempting to get to the Dimension 3 emotional sort of core thing.
So the symptoms that it gathers are very adequate for determining level 3 needs. But you don't need diagnosis to do that. You just need to know symptomatology, how severe the symptoms, And here's one I'll show you quickly. Have you had a significant period in your life where you experienced serious depression, or blues, or hopelessness? So if there's a problem, which this patient has had extremely in her lifetime, was the problem within the last 24 hours related to using drugs or alcohol? And so it actually has to distinguish, are they related to use or intoxication, or related to withdrawal, or you may not even know. And you do need to know that information on all of these symptom clusters, so we do get all of that information.
Great, thank you. And the other question I had was, is it envisioned that this will be developed into a patient self-reported questionnaire, or is it always envisioned to be a counselor-driven interview?
Oh, I'm glad you asked that question, Barbara. So right now, there is an ASI self-assessment tool called the ASI MV, produced by a company called Inflection, which is in use in hundreds of programs across the country. It's endorsed by the ASI authors, Tom McClellan's group at Treatment Research Institute, and it's validated. It gets very good information from the patients. And since half of this interview is ASI, half of this interview can be self-administered to the patient using that tool. And we're in negotiations with that company now. They've actually gone through and looked at the ASAM software to figure out how to pair them up. And we're working on that right now.
Oh, very good. Thank you.
Other questions, John?
I have Dr. Gastfriend, I have a couple other questions, and I'm just going to ask it on behalf of Milwaukee. These are just a couple items that they've addressed.
Sure.
One is for blood pressure and heart rate. They currently do not have the practice, and what they've decided right now is just to consistently put in, and I'm getting those values, I believe, consistently put in 120 over 90 for blood pressure and 70 for heart rate. And I guess they were just kind of, they decided whatever they're going to do, they'll just put it in consistent to kind of control the results. Do you have a strong feeling on that one in terms of should practices that are not recording that, is that something that they really ought to consider doing?
Yeah. So I think for the purposes of the pilot, if they want to put in an average presumed blood pressure and heart rate, as long as they understand that that essentially disables the withdrawal rating, I think that's okay. But blood pressure and heart rate are important for determining a patient's status with need for detox. And so I think, and they're also not hard, a clerk in a CVS can do it. You can actually do it that's something you can do self-administered. Patients can slip their arm in a device and get those numbers out. So I think that, especially as our specialty field increasingly needs to interface with medicine and primary care, I would hope that programs would be willing to move in that direction.
That's great. That seems to be a practice at a couple that we've worked on some meaningful use certification, and that seems to be a practice that is starting to be, kind of put as a common practice in a different software that we work on.
Yeah.
Also,
yeah,
go ahead. Then just another question, and I guess maybe I don't know if it's a question or a comment, but in Milwaukee, they've decided at this point that they will only be, and this doesn't sound like it's restrictive, but that they are only going to be administering assessments on people with the gender of being a male or a female, which doesn't seem like that could possibly be an issue. However, they have different levels of gender categorizations. And my question is that a limitation of the ASAM criteria, or is that just something where we haven't put in different genders into the software yet, but the ASAM criteria supports transgenders and
yeah, I don't think I don't think it has anything to do with the ASAM software, with the ASAM criteria. I just don't, we didn't take gender reassignment into account in designing the items. I don't think adding those items will change in any way the algorithm. So it's literally just a matter of updating the demographic data gathering.
Excellent. And I just have one more question, too. This is an intention.
Tony, actually, before we go from that one, the only thing is, the pregnancy questions are triggered by gender, and so we probably do need to adjust the algorithm so that, we don't prompt, if somebody is a gender reassignment female, you don't need to trigger the pregnancy questions. But that's about it.
Okay, great. Thank you. And then the next question, I don't know if this is really this perhaps is more clinical in nature than even the product, but the question was, can the software be used for continued reviews? And I guess I'm not sure, and I guess this would be, you can perform an assessment and then administer the exact same assessment on a frequent basis. So do you have a kind of any thoughts or opinions on that?
Yeah. So managed care typically likes a residential patient to be reevaluated at least on a weekly basis. And the simplest way to set that up is to open the last assessment and essentially save it as a new administration and go through the previous answers and change the ones that have changed. Outpatient basis, typically for level 1 outpatient, once or twice a week outpatient, managed care generally wants that to be reassessed, I would say at least quarterly. And the same thing, you would go back and reload last quarter's assessment or the intake assessment, and then you'd update things that have changed. Now, one thing we could easily do is highlight the ASI questions that are designed to be reassessed. Not all of them. There's only a subset that need to be redone for reassessment. And then we'd have to do the same thing with the non-ASI questions, the ones that are necessary for step down or transfer or termination of complete care. So there's a little bit of work we would probably want to do to make that stuff obvious and easy. But you don't ask different questions necessarily. It's really the same questions or a subset of those questions.
Excellent. Thank you. Oh, and I also see it's at 2:30. I didn't mean to steal the stage for all the folks that weren't here, but are there other questions that individuals have on the phone call, as well as any action items that we can take for those that are interested in going for the next step, for if they would like to proceed with a pilot? I don't know if that's appropriate or not, but we have our regular calls on Wednesdays and Fridays, specifically designed for providing technical training as well as support and just a forum for anyone that's using the software.
This is Rob, and I have to get off right at this time.
Okay.
This has been a very, very helpful call, and I will follow up with you.
Okay, excellent. Well, I will.
Thank you very much.
Excellent. I'll update this this web page with an encore presentation, as well as tomorrow we'll be available online as well with our call that's scheduled.
All right. Thank you. Bye-bye.
Bye. Thanks, Rob.
Hi, I'm Jonathan Lee, and I wanted just to ask, so for the next step, if the Farm Treatment Center we are interested in piloting the software, then what should we do as the next step?
Well, that's a good question. So from the next step, what we like to do is have you attend one of our, ideally you'd attend one of our technical sessions, and in that one we would go through and assure that we put it in your hands very quickly. We would go through an online training. We could administer it as early as tomorrow. We do it on Wednesdays and Fridays, where we would do a go-to-meeting session. We would transition control over to whichever computer you have there, and make sure that we'll set you up with a pilot site that you could try it out. make sure that you're able to access it.
What time is the training meeting for tomorrow?
The training meeting that we have for tomorrow, and I'll send out a link. I don't know if I have a link to everyone, but it is Fridays. The meetings are from 12 p.m. to 1:30, and on Wednesdays they're from 1:30 to 3 p.m.
Okay.
I'm not sure if I have I'm not sure if you're receiving the email blast. We are trying to email those schedules out. We have an email system that we're still learning how to use. But I can also.
Yeah, in fact, I didn't know about this meeting until I went through my junk mail. So
Okay.
I was able to find this meeting that way. So hopefully I'll get the next one.
Okay. And I'm sorry, that was Jonathan?
Yes, Jonathan Lee.
Okay. I'm going to just, at least I'm going to IM this information out, like in the chat window, but also, I'll see if I can get your contact info too, just to email you to make sure you're aware of it. But the link I just shared with you shows you, where the contact information is for our reoccurring Wednesdays and Friday meetings. And then if there's anything special like today's conceptual call, you can see that as well.
Okay. Thank you.
Thanks. Walter Reed, anything else on your end? I think Dr. Marin and I will follow up, and I'll just make sure I have a consolidated list of where the status and requirements are. I know there are a couple technical details I can consolidate and get them on a page for you. Is there anything else other than those action items?
I think that's it.
Okay. I didn't hear that last piece.
Hi, I just walked in. This is Barbara. I am sorry I had to go deal with a clinic matter.
No worries. I had mentioned that we're scheduled. We'll follow up offline on the items, but I've got a list of things basically to consolidate the information we have, just kind of into get your list and my list of next steps, taken care of, as well as get you the technical documentation that you request.
So I will be at work tomorrow, and there's no clinic business because in the military it's what's called a training holiday. So we could talk tomorrow to iron things out, or certainly on Tuesday.
Okay.
Whatever's good for you. I think my questions are really on the table, but if you consolidate and send me what you have, my email is up now.
Okay. Well, then that's what I might call you tomorrow just to make sure you received my email.
Okay.
But after that.
Back, but that's fine. And then I will really do my best to pin down the IT folks to see if we can get an answer. Because I think it looks great, and I would really like to try it. I don't know about my counterparts right now.
Okay.
But we'll talk more about that.
Okay. Well, that's wonderful.
Helpful. Thank you so very much.
Okay. Well, thank you, Evan, for doing.
Okay. We'll be in touch.
Okay.
Uh-huh.
Bye-bye.
Bye. All right, Evan. Well, I guess this concludes today's call. The recording of the webinar will be available on, on the wiki page that we, the website that we joined shortly. So that'll probably show up there around 5 o'clock today for the meeting notes, and I'll follow up with the individuals accordingly on this one for next steps. So thanks, everyone.
Is everybody else off? Can I talk a little more?
Absolutely.
As I was getting more familiar with this, I was thinking about it in relation to its other potential functionalities besides an intake, because it seems to lend itself so much to treatment planning and to that reassessment process. I think one of the reservations that the inpatient program folks had down at Fort Belvoir was the fact that for the most part they receive referrals, so the intakes are already done. And, and so some of the command folks there were saying this is a whole lot of time to dedicate to doing an intake when it's already been done and we've accepted that patient here. So I could see in my own mind two functions. One is to just do a cross-check, see if the patient you accepted meets criteria, more of a test of the model. And also that reassessment piece, David, that you were talking about.
Well,
but I
also,
wonder if you have found it used for other aspects of treatment that would lend itself to a integrated system like ours, where patients move up and down within more or less the same healthcare system.
Right. So when you get a referral and basically you have to accept the patient,
Actually, have to. It's not a have to. They do assess the appropriate referral. There's conversation before the individual is received by that program.
Okay. So what's the documentation like that comes with the patient? Is it usually very thorough and consistent in all the categories of data it evaluates, or do you find you end up having to sort of redo the psychosocial to figure out, what do we know about this patient?
Yeah. Well, I'm an outpatient. Ours is an outpatient program, so those questions would go more to Tony Decker, since he runs the inpatient side, and so those would be good questions to ask. I know that when we send patients to him, we do a comprehensive biopsychosocial that covers a very thorough, joint commission-based sequence of biopsychosocial and substance use avenues, and all of our diagnostic conclusions are predicated on having the history and the criteria validated. So it's certainly not as comprehensive as what you're showing here, but we have a good measure of confidence that it hits the basics.
All right. So
now that's
I guess,
probably a lot of the people we send to his level 3.5 or whatever it is, 8, maybe could be in a partial if we had that appropriate level of care in our system readily available with a good structured living accompany it. But we know that in advance. It's not like it was a mistaken referral, I would say. But I would say those kinds of questions we'd have to ask him from his referral sources, whether he has to reassess and whether there are cases where maybe they were inappropriate. I guess there isn't too much of that.
Right. I don't mean inappropriate, but for doing the treatment plan, the question is whether it would be helpful to get the additional detail and granularity that this provides, and also the consistency that this provides. And I guess the best way to figure that out is to pilot it and see whether more is learned or whether it really continues to appear superfluous.
I mean, I like the granularity. That's me. I like the details, and I like having a very specific treatment plan, and I like being able to track progress. And one of the things I like about this, and I've always liked about the ASI conceptually, even though we haven't used it, is that you can get the nice data tracking to see improvements in functional areas over time.
Right. I also think that in piloting, if you learn that you're getting much of the information already from the psychosocial that's being transmitted, but you're getting additional granularity and precision, and you're getting probes in areas that they should have done but they didn't bother to, then the question will become a policy question whether you want people to be transmitting this and doing this before they refer a patient to Fort Belvoir. But
and
again,
the other benefit, because we are a really broad system, if we can get buy-in, then it creates that very consistent, systematic model.
Yeah.
Which I think is definitely value added and might be what's expected by our command over time, because we're moving to a new healthcare system here, or at least slightly different structure and very specific requirements for accountability. And so that's what's sort of driving, in part, my interest, aside from the, professional curiosity and interest. I think it really is important for us to be able to demonstrate as a system that we're following right practices and that they're making a difference.
Right, right. So, okay, well, these are, good reasons to do a pilot.
Yeah, yeah. So hopefully, from what I can gather, with your desire to push this out formally in October, the window is very narrow for us to either get on board or wait for it to be, open to the public use. Am I correct that your beta testing is sort of running through October, and then with the conference, you're hoping to have it available for public use, broader public use?
Yeah, it's going to be released nationally at the end of October. So yeah, ideally we'd like to be piloting with you guys, as soon as possible. Get a few weeks of September in, if that's possible. Your counselors will figure out the utility of this fairly quickly.
Yes. I'm not concerned about that. Really, they're very high caliber folks here, and I think they are interested and curious about it. So I think we can certainly press forward and do that once we get a blessing from above. So I'll just do my best to pursue that, and we'll go from there. I do hope to attend, and maybe some of my staff, the conference in October, so then we can see firsthand what's going on with you at the meeting in Arlington. Is it Arlington, the ASAM conference?
Yeah, it's one of the, it could be Bethesda. I forget where it is exactly.
Yeah, I don't think it's Bethesda. That would be very good, but I think it's Virginia.
Oh, okay.
Which isn't far, really. Well, thank you so much for your time, and we definitely will talk very soon, because I want to be able to get some resolution of this if possible for all of our sake.
You bet, you bet.
Okay, thank you. Have a good one.
Thank you, everyone.
All right,
Talk to you later. Bye.
Did Rob get to input any? I didn't hear anything from Oasis at the end.
Let's see who I had in the notes. I wasn't sure if that was Rob or... Oh, I think Rob was interested in... I wasn't sure if I'll have to go and listen again if it was Oasis or the Farley Center, but I thought it was Oasis, was interested in attending the technical training session. So I sent him a link, and I'll send it off to everyone as well, with the link for the training sessions that are on Fridays and Wednesdays. But it sounded like he was interested in attending one of them.
Okay, great, great.
So, excellent. Well, thanks, David. And we'll talk in about an hour.
Yeah, so I think the tour, as part of the conceptual call, can work. I mean, did you think that was okay?
Oh, yeah, it was fantastic. And I learn from this every time too. So.
Yeah, so I'm realizing we don't need to set up two 1-hour calls anymore. We can just do it all in a 90-minute call.
I agree. Really, I think the main reason with how this came to be was just in terms of availability, to make sure that there is at least one way to do it. But I think the conceptual call and the IT portion is a good training, and then the other one is more of a mechanics one, where we make sure that they can access the server, a little bit more of a technical portion. But yeah, I think we are able to do it definitely in one call. Really, the technical portion isn't difficult at all. So.
Yeah. Okay, good.
Excellent.
Talk to you in a little while.
All right, talk to you. Thanks. Bye.
Bye, Tony.